Good evening, everyone. I hope you're all well, and thank you very much for joining us today. My name is Stephen, and I'm here to facilitate today's talk with our experts, Professor Neil Morgan and Dr. Jana Mistry. First of all, we are delighted to see you joining us for our series of easy-to-understand online talks about the health research being carried out at the NIHR Birmingham Biomedical Research Centre. Today's talk will provide an overview of health and care research, including what is and why we do it, but there will be many more talks covering other health conditions over the coming month. So before we crack on to the full presentations from Neil and Jana, I'd like to give you a quick introduction on who we are and what we do at the NIHR Biomedical Research Centre. First of all, we are a collaboration between universities and the NHS. We are managed by the University Hospitals Birmingham NHS Trust in partnership with the University of Birmingham, along with the other partners which you can see here. We are publicly funded by the National Institute for Health and Care Research, which is the NIHR acronym in our name, which is the research part of the NHS. And we are not the only ones. There are 20 biomedical research centres like ours across England, all working to improve people's health. At our research centre, doctors, nurses and other healthcare staff work together with researchers to take new scientific discoveries found in science laboratories and turn them into diagnostics, such as tests or procedures which help identify illness and injury, and also to develop treatments. Our research specifically focuses on the causes, the effects and treatments of inflammation. Inflammation is a normal part of the healing process, and we've all experienced it at some point in our lives, as pain, swelling, heat, or loss of function or movement, for example. However, sometimes the body overreacts, and too much inflammation causes further problems and is linked with many healthcare conditions, including arthritis, infectious diseases, diabetes, and cancer. So before we get started, we want to hear from you. Just a quick reminder that you can ask questions to our experts at any point during the talk. All you have to do is simply click on the Q&A icon at the bottom of your Zoom window, like you can see here shown on the screen, and pop your question in there. We will ask the questions to the speaker at the end of the webinar, and if there are lots of questions, we'll try to pick out the most popular ones. Just a quick reminder, we can't offer medical advice, so we are unable to answer any personal questions relating to your health like this. Also, this webinar is being recorded, and we will share the recording with you after the talk, so you'll be able to share it with others who couldn't attend it today or re-watch it at any time. So, I'd like to introduce you to our speakers today. Professor Neil Morgan is a scientist who studies how genes affect blood and bleeding disorders. He looks for hidden genetic causes of conditions where people bleed too easily, especially when the problem isn't obvious. He leads a large UK project called Genotyping and Phenotyping of Platelets, or GAP for short, which helps doctors better diagnose and treat patients with platelet-related bleeding problems. His team uses advanced DNA testing and tools like CRISPR gene editing to understand how certain genes affect blood clotting. One gene he studies closely is the SLFN14, which can cause abnormal bleeding when it doesn't work properly. He also focuses on people with bleeding disorders of unknown cause, or BDUC for short. And these are cases where people have symptoms but no clear diagnosis. And he's aiming to improve testing and care for them. Dr. Jana Mistry is a specialist registrar in haematology at the University Hospitals Birmingham NHS Foundation Trust, and is currently doing research on bleeding disorders of unknown cause as a clinical research fellow and a PhD student at the University of Birmingham. She is supervised by Dr. Jill Lau and Professor Neil Morgan. Her work is supported by the Thromboinflammation and women's metabolic health themes of the NIHR Biomedical Research Centre. So I'm going to hand you over now to our speakers, and they will take you through the rest of the webinar.
Thank you, Stephen.
There you go. You have control of the slides.
Thank you. So there are around 33,000 people in the UK that are diagnosed with a bleeding disorder, such as von Willebrand disease or haemophilia. But we think that this is a gross underestimate, and there are lots more people out there. And some of those people will have a bleeding disorder that Stephen mentioned called bleeding disorder of unknown cause. And in that condition, they have bleeding symptoms that are significant, but all of their blood tests are normal in the clinic. And that is what our research is focusing on. We're aiming to improve diagnosis for those people. So what is normal bleeding? Of course, when you cut yourself, there will be bleeding because you have an injury. But normally the bleeding stops quickly and the body forms a clot to seal the wound. And to do that, you need cells called platelets, which are in your circulation, and they go and plug the wound. And then you form a mesh of protein called fibrin. And to do that, you need clotting proteins or coagulation proteins. And sometimes you can have a bleeding disorder where the blood doesn't clot properly because you've got a problem with one of those parts of your blood clotting system. And that can mean that people have bleeding that lasts for longer than usual, or bleeding that happens more easily than you'd expect. So one of the reasons that this is important is because if you have excessive bleeding, it can make you anemic. And symptoms of anemia include being tired, being short of breath, and having poor concentration. And it can affect your work and your quality of life and your overall well-being, because essentially you've lost the red blood cells or some of the red blood cells that carry oxygen around the body. So how would you know if you've got a bleeding disorder? Well, generally you would have bleeding from more than one part of the body. So you might have heavy periods that last for more than 7 days at a time, where you have to change pads or tampons more frequently than every 2 hours. You might need pads and tampons at the same time. You might have experienced flooding, or you might have past clots that are bigger than the size of a 50p piece. The other definition of heavy menstrual bleeding or heavy periods, of course, is if you've got heavy periods that are affecting your quality of life. Sometimes people can have bleeding for more than 10 minutes after they cut themselves, for example, if they cut themselves shaving, or they might have nosebleeds for more than 10 minutes. And sometimes that might be because of a local problem, but if you have more than one of these symptoms, then it might be more likely that you've got a bleeding disorder. Some people have excessive bleeding after dental extractions or surgery, and it might be so bad that they have to go back to their dentist or they have to go back to theatre to have more stitches or to have treatment for this excessive bleeding. When you come to our clinic, we will ask you about your bleeding symptoms, and sometimes we use a bleeding score called the Bleeding Assessment Tool Score, or BAT, to put a number on your bleeding so that we can try to measure it. So I've talked about the various aspects of the blood clotting system that can have problems with it, resulting in bleeding disorders. So you can have a problem with your platelets or your clotting proteins, or some people have a problem with the blood vessels themselves. And these can be inherited conditions that run in families, and they might not always show up early in childhood. It might be that you only realize that there's a problem later in life. So, our research, as we've mentioned, is on bleeding disorder of unknown cause. And we have done patient and public involvement and engagement, which means that we asked patients with bleeding disorder of unknown cause what's important to them and what are the main issues in when living with this condition and accessing medical care for this condition. And one of the main issues is that because we don't know what the cause of bleeding is in that condition, bleeding disorder of unknown cause, there's no diagnostic test. So we can't do a test and say, yes, you've got this condition. We rely on a history of bleeding. So somebody might have had excessive bleeding after a tonsillectomy when they were a child, and then they might go on to have heavy menstrual bleeding or excessive bleeding after childbirth. And then when you ask them questions about it, it turns out, well, they always bleed for more than 10 minutes whenever they cut themselves shaving. And it's collecting all of this information that takes quite a long time and means that people wait for a very long time to be diagnosed. So people talk about waiting for up to 35 years before they get a diagnosis. People are concerned that because there's no diagnostic test, that they can't test their children to see if they're also affected. And of course, if they have excessive bleeding with operations, this can have very significant impacts on their health and also affect their faith in the medical system as well. Um, and that brings me on to the treatments that are available. So, for bleeding disorder of unknown cause, we do have some treatments, including tranexamic acid, which stops the breakdown of blood clots, and desmopressin, which sort of boosts the clotting system. But these treatments are not specific and targeted, and they don't work well for everyone, although they work well for a lot of people. So, these are what we call the unmet needs in bleeding disorder of unknown cause. Um, so just talking about the treatments that are available for completion. So if you have bleeding disorders such as haemophilia or von Willebrand disease, we can of course give you clotting factors to replace the problem in your blood clotting system. And if you have heavy periods, then we can sometimes use hormonal treatments like the pill or the coil to make your periods less heavy. Of course, that's not always suitable. So if you're trying to get pregnant, then those treatments are not suitable for you. And then if you've got anemia as a result of your bleeding disorder, we can give you iron tablets so that your body can make more red blood cells. So what I would say about this is that if you think that you've got a bleeding disorder, the first port of call would be your GP to see what they think, and potentially a referral to the haematology team at your hospital. People with bleeding disorders can be looked after at haemophilia or bleeding disorder centres, where we can provide some of these treatments or arrange for your GP to prescribe some of these treatments sometimes. And also we can coordinate your care. For example, if you needed an operation or you were pregnant, then we would work with your the other healthcare professionals that are looking after you to make sure that you could go through those things safely. I'm now going to hand over to Professor Neil Morgan, who's going to talk more about our research.
Good evening, everyone. Thank you very much, Jana, for that really good overview of the clinical problem that we're talking about today. So Jana's PhD is funded by the NIHR BRC, and what we're trying to do with our research is collect blood samples from these patients with BDUC or bleeding disorder of unknown cause. and then collect all the different bleeding histories from these patients and do various surveys and match these to the laboratory tests that we perform. Um, so the idea of doing all these different tests is that we are able to focus in on the different components that may be the reason of why these patients are bleeding. So Jane already mentioned the fibrin. We can look at the fibrin. We can look at the obviously the platelets that help to form the clots and stop the bleeding. So our labs at the University of Birmingham, really our research is really to use really state-of-the-art methods and methodologies to test the blood of these patients. And the aim, really overall aim, is to find some kind of clear diagnosis to explain why the patients that we recruit are experiencing these really lots of bleeding episodes over the years. And so this involves collecting, as I said, the blood samples using advanced laboratory techniques to study the genes within the blood, the proteins, and for instance, if we're talking about platelets, whether platelets function, sorry about that, function correctly. Um, and by comparing the results of these tests from patients and healthy individuals that we need, we hope that in doing this, that patients we can better understand the underlying causes of the bleeding and ultimately improve diagnosis and treatment for this group of patients. So sorry, my slide's skipping. In terms of so eventually our whole aim really is to kind of diagnose the patient's blood. And these were formed into three main groups. So you can see here in this table, there's three main groups of patients from the BDUC cohort that we look at of these patients. So first one is the platelet, where there's a platelet with a platelet problem. So that's the initial blood clotting stage of the whole process. Um, and then the second really group of patients is those with coagulation or the blood clotting problem, which most of you online will know as the cause of haemophilia. Um, and then the third category is those with fibrinolysis. So that is basically how the clots breaks down. So whether it's unstable, if it breaks down, then that can alone give rise to the bleeding. I probably should have mentioned earlier that basically all the normal tests that are done are pre-screened before they come to us in the GAP study. So everything is essentially normal. And you'll see in the table that we've got in the grayed out regions is all these various tests. So these are tests that are very much they are not available on NHS. So they're highly specialized tests, state-of-the-art tests that we're trying to use and implicate and see if these will help with the diagnosis. And eventually what we're hoping to do is if some of these state-of-the-art tests um, give a reason for the bleeding, then we're able then to maybe go back eventually to the NHS and employ some of these more tests that will like really give rise to a better diagnostic outcome for these patients in the future. So that's an overview of what kind of research we're doing with these patients. Um, so finally, sorry, my slide's stuck again. Basically what we're trying to do overall is so by raising awareness to all this research, we can hopefully diagnose patients with the bleeding symptoms by using these multiple blood tests from the three different groups of patients. Um, and then the idea of that is it's important to really improve the diagnosis, their symptoms, what symptoms are abnormal, and then if they are, then they'll be able to seek help in that way. And the result, some individuals, as Jana mentioned, the PPI groups may wait years, up to 30 years, to get the right diagnosis, molecular diagnosis. Okay, so what we're trying to do is really improve the awareness and advance in the research and to help the people get diagnosed earlier, much earlier on in life, so you don't have to go through all these bleeding problems. And obviously, the earlier you get the diagnosis, the better treatments may come in, and we're trying to improve the treatments through all these tests, and also eventually, obviously, improve the quality of life of these patients who've gone through all this history of bleeding over the years. So that's where I'm going to finish off talking about research. So I'll pass it back to, I believe Stephen, who will start off the Q&A question session. Thank you all for listening to our presentation. We've got the Q&A.
Yeah, there we go. Sorry, it just took a bit of time for me to get my camera back on. Thank
No.
you so much, Neil and Jana. It's really, really interesting. Thank you very much for your really excellent talk. I hope everybody enjoyed it and found it stimulating and interesting as well. So hopefully it stimulated some questions from you as well. So we've got some time for questions and answers. If you've got any burning questions now, there's still time to pop them in the Q&A at the bottom of the Zoom screen. We have a few questions within there. I'll take a quick look around them. There we go. So the first question really is from someone called Susan, and it's just a general question. How do people get involved in your study? I think that's probably to Neil.
Yeah, good question. Thank you for that, Susan. Yeah, so what I would say first is generally patients will be referred to via the bleeding disorder clinic. So that will be in the haemophilia centre, and then will be referred as research study to the GAP project, in fact. The other thing to draw you towards is we have a website. So if you just Google GAP bleeding or whatever, and then you will get the information of what a study is all about in more detail and how. But the first port to call is really to go to your GP will refer you to the hematologist in Birmingham it's the comprehensive care centre within the UHB hospital. So they have to be referred by the consultant hematologist.
Thank you. Thank you. Plenty of questions coming in now. Here's another one. So what can the collection of menstrual blood offer compared to normal blood samples for research? Not sure whether Jana can possibly answer that one or Neil.
Sure, I think that's a really interesting idea. And at the moment we're taking blood samples sort of from the vein in your arm. I think it's interesting to consider menstrual blood because it's easy to you don't need a needle to get hold of it. And it would give us information about more local causes of bleeding, potentially from the uterus. But that would be that. I think it's a really interesting idea. Thank you.
Thank you. That's a great question. Next question is, once you have a diagnosis, what is being done to understand the problems linked to patients bleeding?
Thank you very much. So I think this depends on what the diagnosis is. So, for example, if you have a diagnosis where we know what the problem is in the blood clotting system, then that question will have already been answered. But if you've got a diagnosis such as bleeding disorder of unknown cause, at the moment, the standard care is to give people the treatments I mentioned earlier, such as tranexamic acid and desmopressin as needed. And we don't really have the sort of facility to understand what the underlying cause is routinely. It's only if you have access to a research study, such as the one that we're doing in Birmingham, that we would be able to investigate that further and potentially understand that better.
Okay, thank you. I think this is a question for Neil from Lynn. So, would you comment on women with menstrual problems being likely to be recommended for your study? And how can your study be advertised to GPs and other healthcare professionals? Does this section of patients figure largely in your study?
Yeah, that's a good question, actually. So out of our cohort that we have so far that we're working on, the majority, obviously, women, two-thirds are women that have been recruited. I would say largely they have got heavy menstrual bleeding. That's how they referred to us in the first place. Um, I would say we are trying to understand. Sorry, I've lost the. So they will be, as I said, the only way at the moment that we can get referred to the gap is via the consultant hematologists at the specialist hospitals. But in the future, so we're really focusing on just BDUC, but in the future we are going to hopefully open up to more generalized heavy menstrual bleeding. But obviously we need a lot more funding to do that. So we're working towards that in the future. This initial project really opens up, lots of possibilities to answer more heavy menstrual bleeding in general. And hopefully, by using this initial group of patients, we'll be able to really refine the diagnosis and come up with some kind of test that like really open it up for even more um, common causes of heavy menstrual bleeding. Hopefully, I've answered that way and roundabout.
Thank you. A question from Warren, and this is kind of looking to the future, hopefully. So his question was, those patient quotes really struck me, especially the person who nearly died in surgery and is now living with cognitive impairment. The GAP study looks promising, and that microscopy image was striking. But how far away are we from any of this meaning something to the surgeon the night before an operation? Because right now, for the person who's waited 35 years, I'm not sure the finish line feels any closer.
Jana, do you want to answer that one?
Thank you. I mean, uh, you've obviously, yeah, I mean, I can see where you're coming from because people with this condition have been living with this for so long. Um, I would, I think I'd like to say that actually now there's a lot of momentum in the research community with trying to really get to the bottom of this. And there are a lot of groups around the world that are working on this, including our group, of course. And we're just in the process of um, looking at our data, the data that we've got so far, which is showing some promising results. That might be the first step towards a potential positive diagnostic test for this condition. And of course, the more we know about it, the more we will be able to raise awareness amongst our colleagues. And because I think awareness is another issue really around this. So I think you're right, we've got a lot of work to do, but I think we are putting the sort of the wheels in motion now to start to address these problems.
Thank you.
So I hope in the next few years things start to look a bit different.
I
Thank
think just to add to that, Jane, I think when we actually find out what's wrong with these patients, well, what is the tests that come up, the pathologies that, the reason why they're bleeding, then we can begin to look at maybe some new treatments. I think that, that might, rather than use tranexamic acid or others, try to look at some more specific treatments actually that might improve the outcome of these patients with this specific condition. But of course, it's a very complex condition in itself. So, treatment is definitely the way to go in the future. And by doing this initial um, clinical research will allow us to move towards treatment eventually down the line.
Thank you. So a question from Jill. I'm going to add a little bit of a question to it as well, hopefully not to throw you off, Neil or Jana. But as I was going through the presentation, I was really interested to see how many people experience bleeding of unknown causes. And apart from haemophilia, what other possible diagnosis might there be for bleeding of unknown disorder
Yeah. So there's
or
so
unknown causes?
basically so this is what we're trying to do with the different groups. There might be a platelet problem that's not normally picked up within NHS with the tests that are offered there because we're doing more precise, more specialized tests. There might be the so like hemophilia, which is a clotting problem. It might actually be the some rare coagulation clotting factor that might be abnormal, or it might be the fibrinolysis, the actual breakdown of the clot that is a problem. So by doing all these tests, we're able to really kind of work out what the problem might be. And then further down the line, maybe even some of the genetics might even kind of give us some more clues to what the answers for the bleeding. Yeah.
Thank you. Thank you. Right, a question from Monica. I think for your study, Neil, how many participants are you looking for, and how long is the study?
So obviously, we're limited with funding, like how many individual we work on and manpower. So initially we were aiming for about 100 cases, but obviously we can expand that. So for Jana's PhD, obviously that's time limited 3 years, but we will, GAP has already been open for like, 15, 20 years. So we'll continue to recruit these patients. So the study will carry on being open for some time, I'd imagine, especially when we follow up on some of the patients we already find things in as well. So there's no plans really to close this as long as like funding allows us to carry on this research.
Okay,
Yeah, like the BRC have been very supportive with this research, which is why we're here today.
okay. Questions still coming in quite fast. So the next question is, given that you said that it is most likely to be women in your study, what signs and symptoms would you look for in men? And do you think bleeding disorders of unknown cause affects both genders equally, and males are not being identified due to not having monthly bleeds?
Go on, Jana, that's for you, I think.
So the men that have been recruited to our study already have had bleeding after operations. Um, so they might have a big hematoma where they've had surgery. They have excessive nosebleeds. They can also have excessive bleeding if they cut themselves. So um, it's it's possible that um, you're right that because men aren't exposed to um, periods and they don't have this risk of bleeding every month, that we don't necessarily pick up that they've got bleeding. So it might well be that it's the numbers are actually more like 50-50 in reality. But 90% of the people that we're aware of nationally with bleeding disorder of unknown cause are women. Um, so I hope that goes some way to answer the question.
Yeah, just a quick add-on to that. So I wonder what might be able to be done to encourage more males to participate in your study.
So I think the main thing is awareness. So I think uh, the fact that we've got this webinar and we're working with the Haemophilia Society to make sure that any results from our study are cascaded to the people that are sort of members of the society. So I think um, awareness is the main thing here, really, so that people know to come forward.
Okay, thank you. Next question is, can you have both a platelet problem and a problem with fibrinolysis? That's not how you
Yeah.
say it, but
Fibrinolysis, yeah.
fibrinolysis, yes, I couldn't quite
Yeah.
get it in my head.
So, so that's a very good question, actually. So, our initial analysis in our initial cohort with BDUC, what we're finding is we're finding multiple problems. So, you're right, both platelet problems and fibrinolysis. You're right, we can have both. So we believe that the cause of the bleeding within this group of patients is what we call is multifactorial. So there's multiple factors that can, in combination, give rise to this really, really striking level of bleeding in the patients. So we are finding that there is crossover between the different groups. So some might have multiple reasons for their bleeding symptoms. So yeah, we can. Yeah.
Thank you. Um, this next question is maybe something you're doing already, but could you or are you collaborating with gynecology professionals in future
Yeah, so
studies?
that's something we're looking to do to get more funding. So we're already working with people with um with someone in a consultant in the Women's Hospital in Birmingham. And the idea is that when we get funding is to like really bring in more, the reason for heavy menstrual bleeding in general. And hopefully when we finish this initial study, we're able to branch out to this larger group of patients if funding allows. So yeah, we are working certainly with the Birmingham Women's Hospital to do these kind of studies, and obviously nationally as well eventually.
Thank you.
Yeah.
Um, Next question is, do you look at patients' diet too?
Um, Jaina, is that us?
Yeah, thanks.
Okay.
So in the study, we don't at the moment. We're able to access people's previous medical history and their medical information as part of the study if they give us their consent, of course. But we don't routinely ask about people's diet. I think that's an interesting idea. Um,
Could you
yeah.
elaborate maybe on why that diet might be a factor?
So I'm thinking of, I mean, the things that are sort of springing to mind in my head are medications, really. Um, I can't think of anything specific. I don't know if the person that has asked the question could feed back about what their thoughts were about how their diet might affect. I wonder if caffeine can affect
I mean,
platelet
if you go
function.
back to the actual testing in the laboratory, diet can affect, like for instance, platelet function. We know that sometimes caffeine and things like that, excess caffeine can affect like the results of the testing. But whether that's related to symptoms, I don't know. Bleeding symptoms, I don't know. But lots of things can affect the different blood cells within in the body. So
Yeah,
that's something. It's an interesting thing.
it is an interesting question, and I think that person has responded back to think about vitamin K potentially as a factor. I don't
Yeah,
know whether.
definitely. If you're vitamin K deficient, um, yeah, I think that's a great idea. And I can see Dr. Lowe has added in there that we know vitamin C and folate deficiency can contribute to bleeding risk too. Thank you.
Yes, thank you for that follow-up, Dr. Lowe.
Yeah.
Okay, next question is, I haven't quite read it yet, so what what about symptoms that can apply to both genders without implicating menstrual bleeding, like bruised and easy or bleeding gums?
Definitely, these are symptoms that we look for in our bleeding assessments. So, uh, bruising easily, bleeding after minor injuries, bleeding after surgery, bleeding gums. We also ask about blood in the urine and blood in the stool. And then there's other types of bleeding, such as excessive bleeding after you've had a blood test. So you might have excessive oozing after that, or uh, yeah. So the bleeding assessment tool is quite comprehensive.
Okay,
If we use
Yeah.
that.
thank you.
Someone asked earlier about the bleeding assessment tool and how you would kind of, if a GP, for instance, hasn't heard of the bleeding assessment tool, how you would kind of going about, kind of, I guess, educating about the bleeding assessment tool. So how would you, Jane, how
I
would you
think
think that?
I think the main thing when you're in the situation where you think you've got a bleeding disorder, is to ask, well, to explain why you think you've got a bleeding disorder and ask for a referral to haematology. At the moment, those scoring systems are not really routinely used by GPs. But one thing that's quite interesting is this idea of using a self-bleeding assessment tool score that you can get on the internet. And you might want to, I think you might be able to access that or something like that on the Haemophilia Society website. And I think that's quite useful because if you do that and you're getting a really high score, then that could be the sort of evidence that you need to be able to advocate for yourself and say that, look, I've got these symptoms that are really significant and would warrant a referral. So I guess it's a case of being persistent sometimes with that because traditionally we know that people with heavy periods, for example, aren't always listened to. And there's been a recent report that has gone to Parliament from the Haemophilia Society about that. So there's a lot of work to be done about awareness from various points of view.
Thank you. We've had a very another useful intervention from Dr. Lowe regarding the diet issue, and said that some foodstuffs actually do inhibit platelets, for example, garlic and dark chocolate, but it's found that that is a very mild effect and not usually significant. So it's potentially diet could have, but the ones that they know of have a mild effect. Okay. There's been some excellent questions so far. I'll give people a few more minutes to add any further questions they have. But I've got one question, if you wouldn't mind, Dr. Morgan and Dr. Mystery. Is in thinking about the future, what sort of new treatments are being developed now, and what might new treatments look like in the future for bleeding disorders?
I think what we're aiming for with this is that if we identify that somebody's got a problem with their platelets, then we can give them a treatment that is sort of specific to their platelets in the future. So what we're aiming for is targeted treatment, ideally. One potential avenue in all of this is something called rebalancing agents, where you have medications that change the balance between clotting and bleeding in your blood clotting system. But that's very much an area of research at the moment. And so those treatments are not available at the moment. And of course, one of the concerns with all of that is that if you shift the balance from bleeding towards clotting using using these medications, then sometimes you can get blood clots that can also cause harm. So it will be a case of weighing up the balance and doing more research from that point of view, potentially in the future.
Thank you. Okay, I think we're coming to the end of. Oh, there's one just come in. One more question coming, or a couple more. How would you recommend spreading awareness, engaging and educating people who do not know what the Haemophilia Society is or even bleeding disorder? They just know that they bleed a lot and this is normal for them.
I think the webinar is a good start. I think we need more publicity, I guess. Yeah, if you have suggestions about that, then that will be very welcome as well.
I think the Haemophilia Society as well are really helping us to kind of like work with patients from both a scientist, a clinical point of view, and we have these patient groups, so we meet every so often to address some of these kind of issues, and raise awareness.
Okay. got a couple more questions in here, which is great. So the next one's from Warren. The GAP study is sorting patients into subgroups based on where their clotting system is failing. If someone turns out to have a fibrolysis problem rather than a platelet problem, does that actually change their treatment today, or are we still giving everyone the same options we saw on that treatment slide, regardless of what the tests show?
I think this is a really important point. So, given that these tests that we're doing are research based, we always give the caveat that people shouldn't be making clinical decisions on the basis of these test results. So, at the end of the day, it probably comes down to the clinician that is looking after you to make that decision. So, I mean, with fibrinolysis in particular, the reality is that tranexamic acid is generally a very useful treatment because it can inhibit the breakdown of the fibrin clot, but generally speaking, you don't have an increased risk of clots as a result of taking it. And it doesn't have, I mean, some people do have side effects, but the majority don't. And so generally, if somebody's got bleeding and they've got, we can use tranexamic acid, which is specific in some ways for fibrinolysis, then we would do that. So the short answer is no, it doesn't necessarily change their treatment today. But sometimes it can be useful to be aware of what has been found in research.
Thank you. I think we'll come to the last question here. And it's related to blood types. So to what extent does different blood types have on bleeding disorders, and is there any research on this?
So we know that people with group O have less von Willebrand factor, which is one of the clotting proteins, and they have worse bleeding than people that have other blood groups. So that's something that we sort of take into account when we're doing our research. But yeah, thank you for that question.
Thank you. Okay, that draws us to the end of the question and answer session. I'd like to thank everybody who's watching this, everybody who's provided a question. Thank you so much. There's some brilliant questions in there, and also to Neil and Jana for your thoughtful responses as well. I hope you all enjoyed tonight's talk. And I hope you have an interest in research, but if you're interested in actually getting involved in research, there are a number of ways you can do this. You may want to take part in a study or a clinical trial, and there is a national website called Be Part of Research that you can register with to find out which studies are available to you. You can see that this is the website page on the screen, but we've also pasted the link to the Be Part of Research website in the chat, which you hopefully can access. This webinar series has been a result of working with our amazing public research partners, who we really thank for their time and contributions to put on or to supporting the research within the BRC, and also contributing to this webinar and other series. So at the Research Centre, we involve and engage with the public and our local communities in many ways, and we are always looking for new people to join us. Your lived experiences are truly important, and they do make a real difference to research, and I know that for my own personal work. And there are many different ways that you can be involved to suit your preferences and commitments. So if you'd like to find out more about how you can get involved, complete the form that we've just added to the chat to express your interest and to receive information about opportunities from us. You can you may want to help shape the research in the very first place by joining a group. We have 10 such groups within the Biomedical Research Centre, and they're all associated with the different themes of the research that we do within the BRC. You can, if you go onto the Birmingham BRC website, there's a Patients and Publics tab at the top of that, and you can find out more about getting involved in research, and we'd love you to join in. Again, we've put in the chat a link to that page, and we do hope to see that you can find out a little bit more about getting involved and actually shaping the research that we do and making a valuable contribution. So finally, I'd like to thank everybody who's joined us today. Thank you very much. I hope you found it enjoyable, and thank you again for those questions that were made. We really hope to see you in the rest of our webinar series, and our next talk will be in June, which will be focused on the connection between between thyroid disorders and miscarriage. You can find the link to register in the chat. Lots of links in the chat, and we'll also email it to you alongside today's recording. But before we go, we'd really love to hear your feedback about today's event, so that we can improve our next ones. We've just popped the link to the feedback form in the chat, and it'd be great if you could fill this out. It's very quick. It only takes a couple of minutes, and we'll really value any feedback or input that you have. And it would be really helpful for us when we're planning future webinars. So that's it. I hope you enjoyed it all. I'd like to thank everybody for joining, and thank you again to Neil and Jana for your time, for giving such an insightful talk. So thanks very much, and goodbye.
Pleasure. Thanks all.